And let me know when you can see it. I'm going to put it in slide mode. So I won't be able to see you, but you should be able to see me. Okay, can someone let me know if you can see my slides? Yeah, awesome. Cool. Okay, so why don't we get started? So we have an hour today, and I really wanted to focus this hour on introduction to patient safety. What is patient safety? And I'm very big on doing self-reflection and reflecting back on, what did we hear about when we were at MCP several years ago? Now it's almost like 20 years ago. And at that point, I never heard of patient safety. We don't have any patient safety core curriculum, no electives. I'm hoping that changes now, and there's been a lot of discussion. Medical schools, nursing schools, other healthcare professionals, allied healthcare professionals, and patient safety, that there is a need for patient safety as to be part of core curriculum. So I'm hoping for this to be like a primer for all of you, and understanding an introduction of what is patient safety, why it is important, and then how it's really applicable in the real world setting, because that's what I've been doing for the past 20 years since I graduated from MCP. So in terms of an agenda, let me see if I can move my slides. Oh, okay, got it. So agenda, I'll start off with an introduction of me, who am I, what my journey has been. So it gives you a little bit of context of like, where am I coming from, where all have I worked, who all have I worked with, so you can get an understanding of how my journey and patient safety have been interrelated. I'll give you an overview of patient safety. So the importance of patient safety, the national context, some statistics, and then I'll dive into some core concepts and principles. And these are really those big core, if you're learning patient safety science, these are the core principles and concepts that you should be aware of. And if and when you ever do enter into a patient safety profession, into your journey, you will come across them, whether you're exposed to them ahead of time, or if you're thrown right into the mix of it and you come across them. So I'm hoping this is an opportunity for you to hear those concepts before you go into that type of a journey. And then I'll share a little bit from the companies that I've worked with. I worked at a medical malpractice insurance company for 10 years in New York City in their patient safety department. So I'll share some of the key takeaways that I learned there. And then I was the director of patient safety in the compliance team at a EHR software company in Florida. And that was very new for me. I mean, again, in MCP, you knew about hospital, retail, or industry. Those are pretty much your choices. But in the last few years, healthcare opportunities, positions have just exploded, and just new positions being created left and right. And director of patient safety in a software company is groundbreaking. This is one of the few companies that have a safety focus when they're developing EHRs. And then medication safety issues I want to share, since this is our focus as pharmacists and pharmacy students, to make sure that you're aware of what are safety issues that you should be concerned and aware of in your careers. And now that I'm in the federal government, I joined the Agency for Healthcare Research and Quality almost a year ago. It's been 11 months now. So now I'm doing work at the federal level, at the national level. And you basically have to, pull really high up. And my goal is to bring the experience that I had in the hospital setting, in the private sector, and really bring that to government and try to understand, well, what are their needs at the national level? But what can I bring from these individual private sector companies that I've worked at? And then I also want to share some patient safety resources. Some you may have already heard about, but if you have not, that would be a key slide. I would say take a screenshot of it, picture of it, write it down, because they are a wealth of information, and they'll have, webinars and tutorials, but then also have, policies and procedure samples and a lot of other materials that you can continue your learning on patient safety. And then we'll wrap it up for Q&A. So, and just keep me honest in terms of time. I'm hoping to be done my presentation part by 7:15, so that we have a solid 15 or so minutes for Q&A. Does that work with you?
That's fine.
Awesome. Great. So I'm going to dive right in. I don't know if I can move this down even further. No, I can't move that, but we can probably see this is really giving you, I wanted to give you a pictorial view of my journey. I started, pharmacy school in Boston. I graduated 2004 with the PharmD program. And right out of there, where I first landed was at the Children's Hospital of Philadelphia in the inpatient pharmacy. And as I'm sure many of you are aware, if you've already, been working either as a student or a recent grad, hospital environment, extremely fast-paced, extremely challenging, extremely stressful. Inpatient pharmacy allows you to have access to complete patient records. That was one of the reasons why I decided to go the hospital route, after taking courses like MedChem, pharmacology, therapeutics, and so forth. I was like, I want to use that. I don't want to lose that experience of what all I've learned. And CHOP and Boston Children's, they've always been, number one, number two, best, pediatric hospital in the nation. So that's something that CHOP takes a lot of pride in. And it's an extremely fast-paced, challenging environment. Something that I learned over time is, the culture of your organization makes a huge difference. Unfortunately, I wouldn't say it was the best culture there, but I didn't understand that at that time because, again, there was no mention of what is patient safety, what is quality improvement, what is risk, what are those concepts that we should be aware of and be really in a learning type of environment. But I'll save that for another time. So after CHOP, I decided to go back to school full time because I absolutely loved being in a learning environment. So I did a dual degree master's in public administration, which is MPA. So 1 year in New York City at Columbia University and 1 year in London, UK at the London School of Economics. So at that point, I figured, I've done pharmacy, I understand how to use it, but there's so much more to healthcare than providing the care. There's so many other disciplines that are part of the whole picture. So operations, management, financial accounting. I took corporate finance courses, economics courses. And after I completed that, I came back to the US. I was like, okay, now how am I going to apply this? I don't want to go back to pharmacy because I've learned a completely another world of disciplines and I'd like to be able to utilize them. And that's when I joined MCIC Vermont, which stands for Medical Center Insurance Company. They're based right on Wall Street in New York City. And without me even planning on it, I spent 10 years there because the growth opportunities just kept, adding and adding for myself. And you work with really large medical centers, Hopkins, Yale, Cornell, Columbia, and Rochester. Those are the insureds under their umbrella. So I was an associate director there. I started off in the data team as a clinical business analyst. Then I became an associate director, working with chief medical officers, chief nursing officers, quality officers, patient safety officers on clinical initiatives. And then my next step in my journey was, okay, what's next for me? How do I get to that director level? I want to keep growing. What's how do I get out of my comfort zone next? What's growth looking like for me? And lo and behold, I came across an opportunity to join the compliance team at an EHR software company. That's completely out of my, usual sphere, right? We're healthcare professionals. We're used to working with healthcare professionals. Now we're talking about working with the engineers, business analysts, BAs. So I was like, you know what? This is a new opportunity. This is a company that's really pushing the envelope, but they like to say that they're disruptive in the industry. That's a big term, buzzword in the startup culture. This company is now 13 years old, but I have seen it go through its growing pains. It's no longer, a mom and pop shop. They're growing gangbusters, and they're a specialty specific EHR company. So it's not like an Epic or a Cerner or others, where it's a one size fits all. Good luck to you. If you like it or you don't, you can pay for extra, modules or not. Nope, they focus on dermatology, urology, plastics, and other specialties. And they have physicians on staff that actually code and build product as well. So I would work with the engineers, with the physicians, with the business analysts, with sales, marketing, communications, client services. Legal and I were like this because everything that you do in a private sector company that becomes, public facing needs to be reviewed by legal first. So that was an incredibly interesting growth opportunity for me. I have so much more of an appreciation of tech and issues that can go wrong in tech. And I'm going to go into that, into my presentation further. And as I mentioned, for the last year I joined the federal government. So I'm now focusing on patient safety research and building national patient safety clinical initiatives. And that's, I'm still in my learning phase here. It's kind of like mind blown to think that, we're going to make an impact on a national level. But again, it's growth, it's change, it's how I can combine everything I've done in my journey and use it for the good of the American public now. So as I go through this presentation, what I'd like for you all to do is to think about what is your journey. Some of you are just starting your journey. You're still at this MCP, getting your degree point. Others are, 2 or 3 years out or even slightly further out. But think about your path. Where's your path going? Where do you want it to go? And one of the most important things is to be very proactive about it. Don't let it just happen to you, but make sure that you're actively thinking about, where do I want my career to go? So on to the next. What I figured I'll do is, start off now just giving you an overview of patient safety. So start at the beginning. What is patient safety? So I absolutely love WHO's definition. And their definition is patient safety is the absence of preventable harm to a patient and the reduction of unnecessary harm associated with the healthcare to an acceptable minimum. And the discipline of safety is the coordinated efforts to prevent harm caused by the process of healthcare itself from occurring to patients. So the key points I wanted to take away from this one is preventable harm and caused by the process of healthcare itself. So you think about when you go to a point of contact where you're admitted into the hospital, you go to your physician's office for an annual well visit, even you go for labs, you go for, something doesn't feel right. Those are during the process of healthcare itself. You're going to get care and you're not expecting things to go wrong, as they shouldn't, but something goes wrong. And these are issues that should have not happened to begin with. So they're preventable. We're not talking about, known complications of care. We're talking about something has happened that is, shouldn't have happened while you were getting care, and it could have been prevented. So the focus of patient safety is, how do I identify certain issues and how do we prevent them from happening in the first place? In terms of some statistics, so it's a national issue. It's a public health priority. Every single hospital out there has a patient safety, quality improvement, and risk management department. There are 3 different departments and they all intersect together. So despite all the efforts and the progress that they maintain and do at their local level and also at national levels across organizations and shared learning that happens at conferences and so forth, preventable harm remains unacceptably frequent. And sharing some stats here with you, 134 million adverse events occur worldwide every year in hospitals, leading to, as you can see, a large number of deaths, 2.6 million deaths. And 4 out of the 10 patients are harmed in primary and ambulatory care settings. Now, this is going a little bit now into, there's the different sectors or bubbles you can start dividing safety events and occurrences into. You're thinking about inpatient care is one big bucket, you're hospitalized and so forth. And the other large bucket is primary care, ambulatory settings. You're thinking about, you went to your physician's office, a specialty practice, ambulatory surgical center, your pharmacy, labs. Those are all the primary and ambulatory care setting. And as more and more care is shifting to the outpatient, the potential risks on the outpatient side are rising more and more. So actually, when I was at the medical malpractice insurance company, I was part of the team working directly with the vice president and the CMO, chief medical officer, of starting up a physician office practice initiative. We had already initiatives focusing on obstetrics and emergency department surgical specialties, but it was known based on national data that care is shifting more so on the primary care, and more, care that's given there, the opportunity or possibility of risk goes up. So we need to start looking at that. And an estimated 400,000 deaths occur in the US each year as the result of medical errors or preventable harm to patients. So just within the US, even if you don't look at worldwide, that's still a very large statistics. And medical errors are the 3rd leading cause of death after just cancer and heart disease. So it's up there. It's an area of focus that all leadership across all hospitals, they have an eye on. They work very closely with, like I said, safety, quality, and risk leadership and teams within their institutions, because not only is it tied to outcomes, patient outcomes, it's tied to costs. And if you're talking to the CFOs and so forth, that's what they want to hear. They want to hear about the money. They don't really care about the soft and fluffy. They want to hear about what does that mean for our bottom dollar. So that's something that I really learned over time working at the medical malpractice insurance company. And I would say keep that in mind as you go on to your journey. And if you go into whether it's a safety, career, but even within pharmacy, we're all just seeing one aspect of what we're doing on our day-to-day, working basis. But keep in mind, there's other factors, there's other players. And you're thinking like, well, what is the strategic goal? What are the strategic plans? And who's making those? If you got your CEO, COO, CFO, and then you have your clinical leaders as well. And bottom dollar is a huge factor on why companies or institutions, hospitals decide to focus on certain areas versus not. Move on to the next one. So this one's really focused on, so when did the US really start caring about medical errors? Where did this journey really begin and really bring a limelight on patient safety? So if you're familiar with the Institute of Medicine or not, in 1999, they published this landmark, pretty much groundbreaking, eye-opening report, which is called To Err Is Human. So this is something you might want to take a note of or take a screenshot of this picture to read that report. It's again, very eye-opening, very data-heavy, and really focuses on, there was a call for swift reduction of medical errors based on the findings of this report. And one of the key stats from this was 44,000 to 98,000 die in each year in US hospitals due to medical errors. And that was back in 99. And it called for a massive overhaul and massive, comprehensive collaborative effort by government, consumers, healthcare providers, we're talking industry and others, to really come together and say, this is a huge risk for us as a nation, for the American public, something needs to be done about it. And just to put it into context, errors at that scale, it's equivalent to 3 fully loaded jumbo jets crashing and killing everyone aboard every other day, which is, that's unacceptable. And there's a lot of comparison that's done to patient safety in other industries, and aviation is a big one, because like healthcare, aviation is an extremely high risk industry. No one wants to be seeing in the news or, having that experience of being on leadership on any of those airlines that, we have such, experiences with our jumbo jets having such errors. So there's a lot of opportunities to learn from different industries. So what was the response or the next steps from this report? So there's a huge impact on how healthcare is managed. And as a result of that, at that time, President Bill Clinton had signed a bill, which at that point renamed the agency where I am at now. So AHRQ used to be called the Agency for Healthcare Policy and Research, which is now the Agency for Healthcare Research and Quality, or as we call it, AHRQ. And there was a follow-up report in 2001, which is called Crossing the Quality Chasm, which further points out to the original study. So I would say definitely take a look at both of these reports to see if you want to delve in deeper on what were the findings, what were the next steps, who all was involved with these reports, and so forth. But this really marked the genesis of the focus of patient safety in our country. So these 5 points, I've shared this one when I've done education for staff, even at the software company, since generally you're speaking with employees who are not healthcare professionals. So I think a lot of this, these 5 bullet points, they're definitely applicable to healthcare organizations, but they're not specific to healthcare organizations. This just can be applied in other industries. So this is what I say are the 5 core tenets needed to really have patient safety as a core ingredient in your organization. And it takes a total systems approach. And by that, I mean, first and foremost, having a culture of safety. And the 2 key tenets of a culture of safety, and I'll delve into that next, is having a just culture and being a high reliability organization. Those are key 2 big buzzwords when we're talking about having a culture of safety. Next is being data driven. So making sure that, data analytics is a big part of whether it's the department, division, institution, teams. So really have this pragmatic approach of, well, what is our baseline, to identify what are our strengths, what are our weaknesses, what are our opportunities for improvement, and using that data to identify what are our goals, where do we need to focus on. So when we go back and look back a year, 5 years, 10 years back, we say, did we succeed, yes or no? That should not be a fluffy answer. It should be driven by the data, and it should be hardcore, easy to answer based on the data. And I'll definitely tell you, if you've not experienced when it comes to data, people love to like chop it up and deny data. I don't believe in the data that you've provided. We're not going to listen to this data because my experience personally is different. So especially when you're speaking with senior leadership at institutions, you need to make sure that the data and the analytics that you do and you provide, it is rock solid. There has to be no flaw. There can't be any errors. It needs to be backed up by methods and so forth. And if someone challenges it, you need to be able to defend it completely. So having a culture of safety, being data driven, figure out what's your baseline, using the data to identify what are your goals and opportunities for improvement, so you can define success, because ultimately you have to report that back to leadership. You have to report that back to the board. It affects the bottom line and so forth. And also implement preventative strategies. So you're not just playing whack-a-mole, chasing one problem after another. That's literally how I used to, visualize it. When are we going to be done with all the issues? Well, you're really never not, because you're innovating, and innovation comes with new issues as well. But you have to make sure you're trying to get one step in front of it, not just chasing issues that have happened, but say, you know what? We need to understand what else could happen so we can prevent them from happening. And ultimately, it takes a team. So it's not just one person saying, we need to be safe. We need to be a safe organization. Not one team, not one person, not one department. It's everybody. It's leadership. I used to say, everyone needs to drink the Kool-Aid. Everyone needs to believe in having a safe organization, not only for whoever your client is, whether it's a patient or a vendor or a health system, but for your organization, for the longevity and stability of your own organization, to make sure you have a safe approach. So what is just culture? Just focusing on those two tenets of a culture of safety. So a just culture it's pretty much how it sounds. It's fair and it's just for all. And for all really means for everybody, not for just leadership, not for people who are just in the C-suite, not just for the department heads, but for everybody. And really, one of the core tenets of a just culture is always keeping in mind, humans are not fail-proof. We're not robots. We're not going out there to make errors. As healthcare professionals, we didn't go to pharmacy school, nursing school, med school, and so forth with the intent of making errors. But being mindful that errors do happen, because as human beings, they can happen. We're not written by code. We're not robots. But so it's a matter of, how do you manage the expectations and the whole system of understanding, if errors are going to happen, how do we manage those, knowing that they can happen, rather than focusing on the person, like you caused that error. So humans are not fail-proof, and creating a supporting and learning culture. So understanding errors are going to happen, but we're going to learn from them. They're mistakes, and they happen. How do we mitigate them? How do we prevent them as best as we can? But we need to use them as opportunities to learn. If and when any of us have ever failed at anything in life, big or small, there's always that reflection period, right? We're like, well, why didn't this go right? There's a reason for it. So we always need to pause and go back to the drawing board, understand what happened wrong, where did the preparation go wrong? Was it a communication gap? What was a procedure gap? Where in the system was there a failure that allowed that error to happen? And let's learn from it, so we can prevent it from happening going forward. What do we need to change in a process to prevent it from happening again? Having a safe environment to report errors. So adverse event reporting is another big core function in hospitals. Understanding, like, we have an adverse reporting system, online system. If and when things happen, that actually reached a patient, or it was a near miss, it was an issue, but we caught it before it touched a patient. But this is where that data analytics part comes into it. You need to capture the data in aggregate, not onesie twosies, but in aggregate. So over 6 months, over 1 year, how many errors did we actually have? Are we actually a safe organization or not as safe as we could be? And really then doing analytics on, adverse event reporting to understand, well, what are the common themes? Are there common patterns we're seeing? Are they in specific departments? What and where, how do we slice and dice all that information, that errors data, to try to figure out how do we improve? And kind of focusing on what I said earlier, a just culture does not focus on blaming and shaming. It's not about the individual person. I'm not going to shame the nurse, fire the pharmacist, fire, other people who were involved in that error, because many times there's a lot of people who were involved in an issue that happened. And it's not about, let me pluck this person out and put in another person. That doesn't solve a problem. You just change the person. But again, it's another human being. We're complicated beings. How we interact with technology is very complicated. How we perceive technology is very complicated. How we communicate with people, it's nuanced. You could have cultural barriers, language barriers, other issues that are saying, you know what, I heard this, but that person heard something else. So it's not about focusing on the person or blaming and shaming them, but really focusing on how do we build systems, and focusing on systems rather than individuals to prevent an error from happening, regardless of who was involved as a touch point for that patient. Other points, it encourages a questioning attitude. Well, why did this happen? How did it happen? How did we let it to happen? And asking those questions in a non-blaming, non-finger pointing attitude. The point is, going back, we're here to learn. We're here to focus on what happened, why did it happen, so we can understand the root and make a corrective action to prevent it from happening again. And also creating a positive environment for trust. So I can trust others who I'm working with. They're not here to, I don't go to work every day for someone to rat me out. That's what I'm looking to do. So that way I feel, if we're having an atmosphere, a positive atmosphere, a trusting atmosphere, I can say, you know what, I'm doing my job on a day-to-day basis. Things happen. And you know what, I can call myself out when I think I did something wrong. And I'm not going to feel this fear, shame of, I can't trust leadership on what are they going to do to me if I bring something to their attention, because ultimately it's in the best interest of the organization and the patient and the team to do what's right overall. And this just really hit the point home again. It's not about the individuals to be accountable for system failures. It's whatever processes, the individual steps that are in the process to get something done. Like, for example, I had a prescription or a med order. From the moment it touches my hand, comes down the printer, to the time that it reaches, I give it to the patient. There's a bunch of steps. You're pulling the drug, you're filling it, you're checking it, and so forth. You're entering it in the system. Those are all the different steps. So where are the opportunities where something can go wrong? And the last one is a big one that, I had so much appreciation from being at a medical malpractice company. So just always remember, there's a huge difference between human error and malicious and criminal behavior. There's a big difference if someone goes to work and says, I'm going to disconnect your wires, your tubes. I'm going to administer the wrong med to you. And I know I'm doing it because I have my own hidden agenda. Completely different from the majority of us, 99.999% of us who go to work every single day to do good, to do what we need to do for patient care. So always keep in mind, did this happen because someone really wanted to hurt someone, or because, things happen and the system is flawed? And that's what we need to focus on, rather than blaming someone and firing them, because that's not going to solve the problem. High reliability organizations. So what are those? You'll hear organizations, leadership say, we're an HRO, we're a high reliability organization. Safety is important for us. So what are some of the key tenets or traits of high reliability organizations? For one, they're preoccupied with failure. And by that, I mean, they're obsessed with it. They're always thinking about how can we fail? We have a 98% success rate, 85% success rate, whatever it may be, but they're not busy tooting their horn on that 85%, 98%. They're focused on that 2% and 15%. They literally eat, breathe, sleep, get obsessed with, there's still an opportunity where we can fail, what is that? And that's where we need to hone in on. We celebrate our successes, our wins, which is great, but that's not where the work needs to still get done. It needs to get done where it can still go wrong. So first and foremost, they have a heightened sense of vigilance. They're preoccupied with what can go wrong. They have a learning mindset, which ties just right back to the just culture. They defer to experts. So when we work in teams, and everyone has their subject matter expert where they're focusing on. And within an HRO, people keep in mind that someone who's closest to the work, that's the person who knows that part of the work the most. So it's not about, let's go ask the CEO, the leadership, the C-suite about, what do we need to do to solve this? And they're the ones who are, figuring it out in their own silo echo chamber. No, you need to involve the entire team, because the entire team ultimately is part of who is involved in providing the care. The nurse, the pharmacist, the tech, the labs, nutrition, others within an organization, front desk staff, billing, coding, privacy. So many people are involved with providing the ultimate care. And if you're looking to have a privacy question delved into, a billing question, a nursing question, or whatever it may be, understanding that who's the subject matter expert on that part, you go to them, because they're the ones who have the deepest insight. So making sure everyone has this team dynamic type of a mindset. Next is having a sensitivity to the operations. And I would just really summarize that as saying, having a big picture understanding or situational awareness. So yeah, you have your individual core role, your function. That's where your day-to-day lives. But you never lose sight of, well, what's around me? Who else do I interact with before something comes to me? Who do I interact with after, it leaves my desk and goes off to the next? What's the big picture here? So understanding, again, what is the entire cycle of, whether it's a process, whether it's a procedure that needs to be done, treatment, filling a prescription, whatever it may be. You use a classic example in retail. Are you going to involve your techs? Are you going to involve front store staff if and when applicable? And who else is there that we need to involve if and when issues happen? Or are you just going to always go to the pharmacist, the lead pharmacist, or one individual person? And last but not least, having a commitment to resilience. And this is that whole, I keep hearing this, we're going to fail and we're going to fail fast. That's a huge mindset of startups. They're like, we're going into the land of the unknown. And now that I'm in the government, there's so much collaboration that happens with the Army, the Navy, and defense. And those are big areas where we're going into uncharted territory. This is not being done before, but we're going to do it. And we're going to fail, and we're going to fail fast, and we're going to learn from it, and we're going to grow from it. And we're going to figure out, how are we going to fix a problem? We're not going to give up. We're going to be resilient. And every time you fail, you get up, you learn. You fail, you fall, you get up, you learn, and you just keep going, and you never give up. So whether it be, whichever type of an organization you're in, HROs have these, 5 core tenets. And I think a lot of this it's not just specific to organizations, it's specific also and applicable to us as individuals. We all have good days and we all have bad days. So are you going to be resilient, or are you going to give up? And you're going to say, you know what, I shouldn't have done this profession. I invested all this time, money, and energy into what I thought I wanted to do, but I had a bad day. I had a failure moment, a failing moment. And are you going to give up, or are you going to learn from it? And you're going to pick yourself up, take your time to process it. I'm definitely not saying don't do that. Everyone needs that time to just pause. We need to decompress, collect ourselves. But then are you going to get up and learn and grow and move on? Or are you going to let that stop you? So those are the 2 big tenets of a just culture safety, and high reliability organizations. If you're coming from a safety background, you have seen the slides probably to the point where you're, sick and tired of it. But if you're not coming from a safety background, this is another visual that's presented at conferences and textbooks and so forth over and over again. It's called the Swiss cheese model of adverse events. It was really come upon by James Reason, who's one of the founding fathers of patient safety. And this is giving just a visual depiction of how to address safety issues and what they kind of look like. So on the top, left, you have incorrect site on consent. So this is a surgical procedure, something that's a very common: incorrect site or side, left versus right, or site, kidney versus, esophagus, or whatever that may be. The incorrect site has been marked on the consent form. So if we go forth and patient goes into surgery, if nothing gets caught, what's going to happen? You're going to have an adverse event. A wrong site surgical procedure is going to happen. What's going to end up happening after that? Patient may decide to sue after that. That's not what was the expected outcome of this procedure. You need to go back to the OR, which means you're going to be readmitted, additional costs, additional potential risks for infection, additional time needed for recovery, and so on and so forth. So we want to prevent that. This is just one example, but how do we prevent that issue becoming a trajectory and actually touching the patient? So there are several layers of Swiss cheese that are added that are barriers to prevent that error from moving forward and actually touching the patient. So you can educate your staff. You can do training, baseline training, annual training as refreshers, establish policies and procedures, have the best available technology within your facility, have clear communication plans, handoffs, huge time period where there are communication gaps, day shift, night shift, so forth. Checklists, and that's another huge opportunity to learn from the aviation industry. Before any plane takes off, there's a checklist. 1, 2, 3, 4, 5, 6. Are these things all in line? Are these things all done? It's not left to memory. There's only so much a person can memorize. And the more layers of Swiss cheese you have, the less likely that error is going to reach the patient. And you got your little holes in each one of these, right? Which really represents, well, every single layer, great. It helps prevent the issue from happening, but they're not perfect necessarily in each of their own way. Don't want to make that assumption that if you train everybody, nothing will ever happen. Or if you put a policy and procedure together, everyone will always refer to it and an issue will never happen. So you don't want to make that assumption. Each has its own, success rate. So the more that you have, rather than 5 layers, you have 10 layers. What are those 10 layers? How rigorous are they? So keeping in mind, again, error can happen, but did that error reach the patient? That's what it's all about. Did we catch it before it actually touched somebody? If you can imagine, errors are happening, but they don't touch anybody. That is ideal state. That's what every institution aims for. So that's the Swiss cheese. And there's 2 really big buckets. Like I talked about inpatient, outpatient, there's 2 big buckets of approaches on how to address safety issues. And they're really the reactive approaches and the proactive approaches. So reactive is you can do a root cause analysis. And I'll go into that next. You can look at adverse event data. That's because something has happened. Now we're going to delve into the data, figure out what happened. You can look at medical malpractice data, claims, suits, events, but they're lagging. This is something has already happened. Now we need to fix it and prevent it. But what we want to do is actually get on, like I said, get in front of it. How do we prevent something from happening? So you do failure modes effective analyses. I'll speak about that one next too. Be an HRO, a high reliability organization. Do training, education, be transparent, have a just culture and so forth. Do automated testing for your EHRs rather than manual testing. Have a collaborative approach during project development. And the sweet spot really is right here in the middle. You're going to have to do both. You have to do both routinely and regularly. So keep addressing issues that do happen, because they will happen, but also stay in front of it to figure out how do we prevent other things from happening altogether. I think we have a little over 15 minutes, so I'm going to go a little faster. An RCA, if you've not heard about, this is after the effect, after an actual event has happened. So rather than focusing on the weed, you just keep pulling the weeds out. Weeds are going to keep growing because the problem is not up here, it's underneath. So you have to keep asking the questions of what happened, where did it happen, when, why, how, who was involved, did we have insufficient teams, insufficient training, and so forth. And it's really about, you don't keep just putting out the fires, but try to way to implement, add another step in the system or change something in the system that's going to prevent that issue from happening going forward. An FMEA, the failure mode and effect analysis. This is even before something has even happened. So you know what? We're dedicating time, we're putting a team together, and we're going to look at this particular processes. We know it's, not ideal state. It works pretty well, but it can be better. So how are we going to prevent an issue from even happening before it does? So again, ties back into the high reliability organization. So it's an 8-step process. I won't go into details on all of them, but you're going to create a team, and the team should be people who are all part of a particular workflow, not just one or two, but everyone who's part of a workflow. What are you going to focus on? What are the steps in that process? What are the potential issues that can happen where, I've seen this breakdown before. We've caught it before it touch anyone, but it can happen. And then you rank those type of issues, you identify opportunities and solutions, you rank them, and then you ultimately at the end you come up with like this a plan, a mitigation plan on what we're going to change the process, we're going to test it, small pilot of change, and then come back and revisit it a month, a few weeks, 6 months later, like, did our FMEA process work or not? So it's really the whole reactive approaches versus the proactive and reactive. So I'm going to go pretty quick on this one. So med-mal perspective. So as I mentioned, I was at a med-mal insurance company for 10 years. If you're not familiar with this, hospitals aren't insured by traditional insurance companies like the Aetnas of the world. It was like in 1978 that traditional insurance company said, you're way too risky. We're not insuring you anymore. So hospitals now self-insure, they're captives. So the Harvard hospitals, the partners, they have RMF Crico. The insurance company I worked with, they had Yale, Hopkins, Cornell, Columbia, and Rochester, and they all come together and then they pool their risk together. So if someone's failing, others are feeling it too. So they have a vested interest of let's all work together, let's standardize, let's learn best practices from each other, let's share, don't reinvent the wheel. If you've had successes, you've had failures, learn from each other. And they focus really on high dollar and high frequency losses. We're not talking, hand washing technique here. We're talking about obstetrical risk, emergency department, surgical specialties, the physician office practice. OB is number one nationally because you're talking about risk to mother and baby. People, I'll sue you if you got my wrong, organ out because that's not what should have happened. But if you cause injury to my baby, I'm coming for your jugular. It happens, multi-million-dollar lawsuits. Fetal distress, shoulder dystocias, when you're pulling on the baby during childbirth, the amount of pressure that is put on this nerve here on the neck results in a brachial plexus injury, which is basically nerve damage, can result in lifelong, paralysis or nerve damage. People come at you with the big bucks for that one. Delays in admission in the ED, failure to rescue. Someone literally had a heart attack while waiting to be seen after 6 hours in the ED. People come after you for that. That's not what should be. These are all preventable issues. Physician office practice, that's an area that I was focusing on. So failure, delay in diagnosis, that's again number one in the US, and failure, delay of diagnosis in cancer diagnoses, number one area for med-mal. Person went from stage 1 to stage 3 because the doctor didn't call me back, or they called me back 6 months or a year later than I was supposed to. I didn't hear back, and now I have an advanced illness. Patient identification, verification issues, and others. Strong emphasis on data. You're slicing and dicing the data in multiple ways. You're doing by institution, by department, by what the patient's alleging, the contributing factors, and so forth. And you're working with several people. You're working with physician and nursing leaders, chief medical officer, chief operating officer, chief quality officer, chief nursing officer, patient safety officer, and many others. So you're working on, multiple levels. This one I'll just talk very briefly on the hierarchy of effectiveness. So rather than speaking about the different initiatives that we had at the insurance company, there's a hierarchy of, effectiveness. So keeping in mind when you're trying to implement best practices, help these organizations, there's certain strategies that are better than others. They're more rigorous. So are you going to keep telling someone to just be more careful? just be more careful because you think that's going to work. That does not work. You need to get up here where they're most effective, but hard to implement. So you need standardization, you need CPOE, you need forcing functions, you need to remove certain medications from that floor, from the unit, because it's not applicable here. These are just two versions of the exact same thing. I just love both of them, so I added them here. This is from ISMP, which is the Institute for Safe Medication Practices. I would definitely say write them down too, since that's so relevant to our area of work, and delve into this type of a diagram in further detail. EHR safety risks. So again, I have so much more of an appreciation of what can go wrong in the EHR. You go to your doctor's visit and you expect everything's, being documented correctly, saved correctly. It may not necessarily be true. There's a lot of moving parts here. It's either, information can get lost. It's not where it's supposed to be. It's in a different tab. It's in the wrong patient's chart, which is basically a compliance nightmare. And what are those top areas of risk? So orders. So we're talking labs, radiology, pathology. Again, it goes back to delays or failures in diagnosis, right? Results didn't come back. They went to the wrong patient's chart. Medications, that's our area of focus, right? I ordered the wrong med, the wrong dose, the wrong dosage form. The instructions fell off of when you document it and hit save. And there's several others. There's a huge list of potential safety risks within an EHR. But, family history, vitals, vaccination status, implants, and so forth. I will tell you, I literally just went to the dentist a couple of months ago. And when I'm sitting backwards, in the chair and I can see the screen behind me, I was like, that's not my age. You're in someone else's chart. So I would say to everyone here to be extremely vigilant, be proactive, and be part of the process. When you go to the doctor, ask questions. Don't make the assumption that they're in the right chart. I mean, they hopefully are, and most of the time they are, but look around like, yes, that is my chart. What are you documenting? Can you repeat back what you documented? And so forth. You have to be a proactive member of your care. These are just some examples of actual safety issues. So laterality got switched to left versus right. X-ray details were removed, medication doses not saved. So you got your drug name and your instructions, what happened to the dosage? Well, I wrote it, didn't save right, or it saved incorrectly. Lab results went to the wrong patient. Incorrect patient images, which is huge. You have a different female or a different male, female in your chart. So how do I know I'm documenting in the right chart? This one I'm going to breeze over, just really the definition of what are medication errors. The FDA receives over 100,000 reports through MedWatch every year. Again, focus on the analytics. There's multiple points of errors, so ordering, prescribing, documenting, transcribing, and so forth. And the most common errors are during the ordering or prescribing phase. And ordering errors account for almost 50% of the meta errors. And this is where we come in. Nurses and pharmacists identify anywhere from 30 to 70% of these errors. So something to keep in mind when I get to the last few of my slides. Causes of medication errors, it could be a plethora of them, incorrect dosage form, allergens, you're prescribing something or dispensing that shouldn't be, person's allergic to it, contraindications, you didn't check LFTs. That's what why I loved working in a hospital setting, because you have access to liver function data and so forth to make those decisions and have that conversation with the physician staff. There were distractions. There are literally rooms in hospitals now that are distraction proof, like the nurse or another clinician goes into that room and everyone knows if you're in there, you do not distract them, whether they're doing admixing or they're doing med rec or whatever they might be doing. You do not distract them, because distractions are another big known cause of errors. You're basically breaking a person's chain out trail of thought. And there's multiple strategies, the 5 rights to med safety, right patient, right route, and right time, drug, dose, double checks. I'm a big fan of double checks. I've so many issues have been caught because of double checks. Makes me wonder if triple checks would be even better. Something to think about. So now I'm just going to wrap it up. So national focus, now that I'm in the government, what are some key areas that we talk about? One, focusing on equitable care, not equality, but equity. What is equity? Having a culture of diversity, keeping in mind we're a diverse population in this nation. We have to be very mindful of that when we're working on national strategies. Focusing on the whole person. I'm not just focusing on heart, liver, lung, a particular organ system. No, we're taking care of an entire person, their family structure, their financial situation, their educational level, their literacy level, where they live, how they transport back and forth to a clinic, a hospital, and so forth, and really focusing on improving health outcomes on underserved communities. That's really where the big national need is. And something I've learned just recently in my 1 year here in government is there's a huge gap between research and practice. I'm not sure if any of you heard this stat, but this was a big one for me. It takes 17 years for 14% of original research to be translated into patient care. I've never heard that one, but it's in the literature, and it was like mind-boggling for me. Like, you come from private sector, you come from a hospital environment, no one's gonna wait 17 years for someone to give me some research to work with, and 14% is literally nothing. So we need to go faster on a national level to get best practices, strategies to the front line so we can make impact sooner, faster, now. And really challenging your own assumptions. Like, we make these assumptions, we'll have patients fill out these electronic forms. You're making an assumption that everyone has access to technology. Not true. You're making an assumption everyone has access to electricity. Not true. You're making assumptions everyone speaks English. Not true. There's so many assumptions that we need to challenge when we're focusing on initiatives at the national level, because it really impacts everyone. And that's extremely humbling. And I love that, that there is a focus on that within the government. And the last thing that this says here is healthcare is not safe until it's safe for all, which I love that. That's one of our core tenets. These are just some really good depictions or visuals of what is equality versus equity. I'll just go over one of them. They're both saying the same thing. So when you say I'm going to give equal care, for example, everyone wants to see a ball game, but they're all different types of people. So if I say I'm going to give you an equal best practice or equal opportunity of what I'm going to give you actually as a tool to watch the baseball game, I'm going to give everyone the same box. But what we forgot to take into account is everyone has different circumstances, different parameters to them, that this doesn't work. This is what ends up happening. What we need to do as equity is really focusing on taking into that, again, that whole person consideration. Someone's taller than the other person. They need 2 boxes and they don't need any. They didn't need any to begin with. So again, there's a lot of great illustrations on equality versus equity. I'll definitely say to take a look at those. Just bringing it all together, patient safety, what we used to say at the EHR company, safety is everyone's business. It's important for all of us. At one time or another, all of us will be patients. All of our family members, our friends, our neighbors will be patients. So focusing and finding value in patient safety serves all of us. As an organization, as an institution, it's a liability risk to be mindful of. It has financial impact, bottom line. It impacts the relationship patients and providers have with each other, and also the brand and goodwill of a company, especially if you're coming from private sector. This one I won't go into. I would say take a screenshot of it, take a picture of it, of several different resources. WHO has a lot of resources on safety. ISMP, they're the ones who really focus on med safety. It's directly related to us. Patient Safety Movement Foundation, and even on MCPs on their alumni courses, I've seen a lot of CEs. This one's great. The Pharmacist Liability Claim Report ties right back into my MedMal experience, because I think it's great for pharmacists to know whether you're starting your journey or somewhere in the middle of, well, if other pharmacists have been sued for something, what was that? So I'm aware of it. May not ever happen to me, but it may. And how do I make sure I'm prepping myself to prevent that? So long story short, I think we only have 3 minutes. So just tie this all together. So your journey is probably here, finishing MCP, or recently just started out of there. So thinking about your journey, where is it taking you? Where's your path? And the main things I'd say is, keep your ears and eyes open, be open to the new and unknown, because you really never know. Like I said, when I started retail hospital industry, that's all you had as an option. I went to an insurance company. I went to a software company, and now I'm in the government. Those weren't even, talked about when I was in MCP as potential opportunities. So you really never know. Do not be afraid of the unknown, because it's a journey. Enjoy it. Keep learning, keep enjoying the process. Don't get so rigid. Well, I need to do it this way or that way. And advocate for yourself, your careers. You've put in a lot of time and energy and effort into these 6 years. That's a huge investment. You have to advocate for your patients, whichever setting you're in. Do not ever forget why you joined and went to pharmacy school to begin with. Advocate for your teams. If you go into management, you go to private sector, you're probably going to have people reporting to you at some point. So you're going to have to advocate for them too. You are their leader. And also, if you go into government, you're advocating for the American public. Last thoughts, and this is the first one, is something my boss used to tell me quite often at the MedMal company, which I love. Make sure you're always performing at the top of your license. You have a PharmD. It's a doctorate degree. It's a professional degree, and you owe it to yourself to perform at the highest caliber of your mental capacity, your professional capacity, to use what you've learned in all these 6 years. And you are leaders, and well, really end it with, you are patient safety professionals. I'd say you're just not branded that way. We're not branded that way yet, but we are. Every time you check a prescription and order, you try to make sure it's correct. What's wrong potentially. Our brains are really wired to find what's wrong. I know something's wrong here, and until I prove it to myself, the script's not going out. That is a patient safety mindset, right? You're preoccupied with something that's not right. And until you prove it to yourself, that script's not going out. So yeah, I'm going to end it there. I don't think we even have a minute, but I will stop there. Hopefully I can figure out how to stop sharing. Yeah. So I don't know. We only have like a minute. So